This lecture is an introduction to acute leukemia and the approach to initial diagnosis of acute leukemia for those of you on the hematology rotation. It's meant to be a brief introduction and is not a comprehensive review of this topic. Our learning objectives are to develop a general approach to hematologic neoplasm classification for you to be able to identify presenting features and complications of acute leukemias, and to identify the initial workup required for patients suspected of having acute leukemia. In general, when we talk about a neoplasm, as you know, a neoplasm is an abnormal growth of cells, and this can be either benign or malignant. In the world of solid tumors, malignancy is also often characterized by the ability of that abnormal growth of cells to both invade other tissues and to spread to distant sites or metastasize. Unfortunately, in hematology, these definitions do not apply because blood and bone marrow is always circulating and fluid and is not confined to any geographic space in the body. Therefore, in hematologic malignancies, when we discuss a malignancy potential, we talk about clonality. So we look at whether or not the group of cells are genetically identical and have a single common ancestor, or as we say, clonality. The clonality in hematologic neoplasms is defined as having cell surface markers that are all the same, particularly in lymphoid neoplasms, or if there is evidence of a molecular or cytogenetic marker that's consistent throughout the cells, again, identifying that they are clonal. When we talk about hematologic neoplasms and malignancies, often we will link that back to what's the normal morphologic precursor cell that cell is most alike with. So it's important to have a general idea of the hematopoietic process. So when we think about hematopoiesis, we know that all cells start as multipotent stem cells in the bone marrow. The first differentiation point is between myeloid stem cells and lymphoid stem cells. These lymphoid stem cells then go on to form your B and T lymphocytes, whereas your myeloid stem cells go on to form the rest of the blood system, including the myeloblasts differentiate into your granulocytes with the basophils, eosinophils, neutrophils, and monocytes. The megakaryoblast go on to become megakaryocytes and eventually platelets, and the erythroblasts go on to eventually become erythrocytes or red blood cells. It's important to think about in hematologic malignancies that there can be characteristics of an increased production of cells, which is the most common feature that people tend to think about. However, there can occasionally be decreased production of cells. These patients can present with cytopenias. And often there's abnormalities of cell function. So just because a leukemic patient has some neutrophils floating around, it doesn't mean those are functional neutrophils, for example. So this is an oversimplification. However, I think it's useful for understanding the broad strokes of how we characterize hematologic neoplasms. The first differentiation point we make is whether or not a disease is myeloid or lymphoid in origin. And this has implications particularly as these two different classifications respond to very different drugs, and it has both therapeutic and prognostic implications. Next, we look at the breakdown as to whether or not something is acute or chronic, and each of these quadrants has a prototypic disease that helps us understand the nature of these diseases. So on the acute and myeloid, we have acute myeloid leukemia. Under the chronic and myeloid, we have myeloproliferative neoplasms. So this would include diseases like chronic myeloid leukemia and the non-BCR-ABL myeloproliferative neoplasms such as polycythemia vera or essential thrombocytosis. Under acute and lymphoid, we have acute lymphoblastic leukemias or aggressive lymphomas such as a Burkitt's lymphoma. And under chronic and lymphoid, we have indolent lymphomas like follicular lymphoma. We also have chronic lymphocytic leukemia or CLL. Now, the acute and chronic differentiation is important. The acute diseases tend to be rapid in onset, rapidly progressive, and rapidly fatal without treatment. And in general, these are clonal proliferations of immature cells. So if we go back to this picture, the acute neoplasms tend to be proliferations of the myeloid stem cell, lymphoid stem cells, or perhaps of the myeloblasts, megakaryoblast, erythroblasts, or maybe even these earlier precursors in the granulocytes lineage. When we move over to the chronic side, these diseases tend to be gradual in onset and slowly progressive. Often patients will live with these diseases for years before someone diagnoses them if they don't access healthcare often, or if their physician doesn't do regular blood work. And once the diagnosis has been made, often these patients live for many years with the disease, and in many cases, we do not even initiate therapy until the disease is causing problems. In this case, chronic diseases tend to be clonal proliferations of mature cells. And the morphology will be much more similar to normal morphology in the chronic diseases in general. So now let's look at a case to illustrate this point. A 53-year-old gentleman presents to a hospital feeling unwell with generalized fatigue. He's found to be tachycardic and have mild decrease in his oxygenation saturation. The emergency room physician does blood work, and his complete blood count shows a hemoglobin of 90, platelet count of 150, a white blood cell count of 200, with a differential diagnosis pending. I'm going to give you a minute or two to think about what is your differential diagnosis. And I encourage you to think, again, that we do not have a differential, and you should keep your differential on the white blood cell count, and therefore your differential diagnosis should be kept fairly broad at this point. So, as you've probably come up with, the differential diagnosis would include some acute leukemias and some chronic leukemias, because we don't know whether or not that white count of 200 is made up of immature or mature cells at this point. So the differential would include acute myeloid leukemia, acute lymphoblastic leukemia, chronic lymphocytic leukemia, chronic myelocytic leukemia, and less commonly, but still to be included in the differential, a chronic myelomonocytic leukemia. I think this is, something that when we're seeing residents going through these cases in real life, often, they'll just say, well, it's leukemia. And I'll say, well, what are the possibilities? Leukemia is a group of diseases, not necessarily the specific disease. So good to think about what are all the options. So when we get the differential back from the white blood cell count, it shows 90% blasts with an absolute neutrophil count of 0.9, and you diagnose acute leukemia. May I just remind you that a diagnosis of acute leukemia requires a blast count of 20% or higher in any blood, bone marrow, or body fluid cavity. So 20% blasts in the blood, 20% blasts in the bone marrow, or more rarely over 20% blasts in a collection of hematologic cells in other tissues, such as in the skin or in the muscle, like a myeloid sarcoma. Any of that gets you a diagnosis of acute leukemia. So now I'd like you to think about what else you'd like to look for on your clinical evaluation. So not investigations, but your physical exam and history. And I encourage you to think about this as think about what will happen to the patient as a consequence of cytopenias, consequence of the high white blood cell count, and of potential infiltrative symptoms. So if we break it down in terms of low hemoglobin, patients may have pallor, fatigue, shortness of breath, or palpitations. The low neutrophil count can present with fever and infection, not uncommon. It's very important to do a thorough search for infection in these patients. The low platelet count can present with bruising or bleeding symptoms. And if they present with DIC-like symptoms, then they may have clotting as well. So it's not uncommon, it's not common, but not uncommon for us to see patients present with an acute thrombotic event, such as a DVT or PE, when they're diagnosed with their acute leukemia, which makes those patients very difficult to manage. Then we move on to infiltrative symptoms, so bony pain, hepatosplenomegaly, more common only in lymphoid leukemias, because lymphoid precursors reside in the lymph nodes and the spleen. You'll only see a big spleen in a myeloid malignancy or myeloid leukemia if it's transformed from a pre-existing myeloproliferative neoplasm. And then in terms of infiltrative symptoms in the skin and in the gingiva, this tends to happen in monocytic subtypes. And those are also the patients that are increased risk of DIC, so keep that in mind. That's a good clue on your physical exam. And then lastly, with a white count greater than 50, patients are at risk for leukostasis. So this is it's typically a white count of immature cells greater than 50 or a blast count greater than 50. And those big blasts are both large and have increased cell adhesion molecules on their cell surface, and they tend to cause problems with flow through the microvasculature of your capillaries. The organs greatest at risk include your CNS and your pulmonary organs. However, any organ system can be affected. And again, this is just a reminder that the myeloid precursors reside in the bone marrow, lymphoid precursors reside in the lymph nodes in the spleen and the bone marrow, and that's why the lymphoid neoplasms tend to be the ones with lymphadenopathy and splenomegaly. So for the initial workup, we're always thinking about what are the effects of the disease and is the patient fit for treatment for any malignancy. So we're obviously going to do a complete blood count, peripheral blood smear, bone marrow biopsy, and aspirate to further characterize the disease, looking for tumor lysis with increased cellular contents being released with a high cell turnover from those leukemia cells. So there you can see a high potassium, high phosphate, high uric acid. You can have renal dysfunction. The liver panel is to assess fitness for treatment, whether or not they'll tolerate chemotherapy. Coags and fibrinogen, looking for that DIC. Chest x-ray and abdominal ultrasound if you think it's a lymphoid leukemia. The chest x-ray is done as a baseline for everybody. All these patients are going to get blood products. They're all going to be at risk for infection, so we want a baseline chest x-ray. As well, they get a PICC line for their peripheral chemotherapy administration and a MUGA scan to assess their cardiac fitness for chemotherapy. In general, the acute myeloid leukemia treatment is induction chemotherapy given with idarubicin and cytarabine on day 1. This is a 7-day regimen. They get a bone marrow biopsy at our center at day 14 to see if they have any residual leukemia. If they do, they get additional chemotherapy. Then they get a bone marrow biopsy at recovery, which is typically day 30. We need a platelet count of 100 and a neutrophil count of 1 to be able to do the recovery bone marrow biopsy. If this is clean, patients go on to get consolidation chemotherapy to ensure that the leukemia does not come back. And for high-risk patients, they'll go on to get an allogeneic stem cell transplant as their final consolidative therapy. After any of these cycles of chemotherapy, induction, and with consolidation, patients will drop their blood counts for usually 2 to 3 weeks after, and they'll have severe cytopenias requiring transfusion, therapy support, and significant and severe neutropenia, putting them at risk for febrile neutropenia and infection. The risk is so severe for our induction patients that we keep them in hospital for the first month. And consolidation chemotherapy, patients tend to get the chemotherapy, then go home, get transfusions in medical outpatients, and they're only readmitted if they develop a fever and infection. When we talk briefly about prognosis, acute myeloid leukemia is the most common leukemia in adults, and the outcomes depend largely on the cytogenetics and molecular testing, which is our best way of risk stratifying these patients. For good and favorable risk patients, their 5-year survival is 60 to 70%. Intermediate to normal, the 5-year survival is 40%, and poor to adverse, the 5-year survival is less than 20%. And these numbers are without stem cell transplant. So we send these intermediate to poor risk patients for stem cell transplant to try to get their 5-year survival up to this 60 to 70%. Transplant itself has anywhere between 15 to 30% treatment-related mortality, meaning that you will die from the treatment alone because it's so toxic. Therefore, we do not transplant patients with good or favorable risk disease because they do reasonably well without the transplant. There's no point in putting them through the toxicity of the transplant with little added benefit for their survival. So that's what we're saying here. Good prognosis, the toxicity of transplant outweighs the benefit of chemotherapy alone. So that concludes our introduction to leukemia and specifically acute myeloid leukemia. If you have further questions, please don't hesitate to contact us.